hopefully that you take home an anatomical clinical pearl that will facilitate correct needle placement during a paravertebral or neuraxic block. And you'll also be able to demonstrate some morphological aspects of local anesthetic spread during these two techniques. Thoracic paravertebral block is a technique of injecting local anesthetic into a wedge-shaped space which is retropleural. It's adjacent to the intervertebral foramina, and as a repository for local anesthetic is quite interesting because it's not only the somatic nerves, but it also contains the sympathetic fibers. So when you inject a local anesthetic nerve, and as illustrated in these images, local anesthetic not only spreads in the paravertebral space, but it also spreads to the intercostal, the epidural, the ipsilateral epidural, and occasionally by the prevertebral route, it can also spread to the contralateral side and to the contiguous paravertebral spaces. Thereby it produces ipsilateral somatic and sympathetic nerve blockade that's effective for analgesia or anesthesia, where the afferent nociceptive input is predominantly unilateral from the chest or abdomen. And there are a host of indications about this technique. As a technique, ultrasound has gained in favor in recent years, and when you perform an ultrasound-guided paravertebral block, you either perform a sagittal or a transverse scan. Today, there are no data to suggest which is better of the two. There are proponents of either technique. Hopefully today, I will share with you some of my own experience of performing these blocks, and hopefully you take away some messages to why one may be preferable over the other. Now, when you do a sagittal scan, before I mention about that, I think I'd like to invite you to go and review this paper and a lot of credit should be given to Dr. Credier and his group for reviewing a paravertebral block, and that's available in anesthesiology. As you will see here that you can perform a transverse or a sagittal scan. You use three important landmarks, which are primarily the rib, the tip of the transverse process, or the inferior articular process. And needles have been introduced outer plane, in plane, from medial to lateral, lateral to medial direction. So much so that it leaves you as a reader confused as to what you should do in your clinical practice. Hopefully I will try and illustrate to you what may be preferable in this situation. The sagittal scan is quite simple. You perform a paramedian sagittal scan using a high-frequency linear transducer, as illustrated in this image here. What you see is the transverse processes and the globular ribs, which are anteriorly, and then you see the paraspinal muscle, including the erector spinae, the superior costal transverse ligament complex, and the pleura. But ladies and gentlemen, I'd like you to take a look at the pleura. You'd agree that it's a little bit fuzzy. It's not as clear as you would expect to see a clear, bright line. And this is usually a problem of performing a sagittal scan at the level of the transverse process. And I believe this is because you have an isotropy. If you look at the image, these two cartoons you will see on the left, where the beam is insonated, you see that because of the anterior-medial reflection of the pleura, the beam is not at right angle to it. So based on physics of ultrasound, you get a fuzzy image. So we've also reported that you can get a better image if you tilt the probe slightly lateral. So an outward tilt would get you a real clear delineation of the pleura, when in a true sagittal scan, you do not get that. So that's the first pearl for you. If you're doing a sagittal scan, tilt the probe slightly outward. But the pitfall for that is that because the transverse process is very closely related to ribs, it's conceivable that if you tilt the probe too much lateral, you're going to look at the ribs. So, and an injection at the level of the ribs may not behave the same way as at the level of the transverse process. Nevertheless, sagittal scans have been reported in the literature. Hara and his group from Japan were the first to report about it, and this is the first report of 2D ultrasound being used for performing paravertebral blocks. They located the transverse processes. Needles were inserted out of plane. I guess because of the poor visualization, they also used loss of resistance. And once the needle entered the paravertebral space, they could see displacement of the pleura, anterior displacement of the pleura in about 20% of their patients. And they also saw turbulence within the paravertebral space in the ultrasonography. But I'd like you to take note of this particular statement, which I've highlighted in red. They said they were unable to delineate the pleura at the T1 level. So visualizing the pleura at the upper levels are challenging. And if you are performing paravertebrals as a multi-level injection, this is something you need to keep in mind. Another group from Ireland also reported on the Sentinel Scan. They introduced the needle in plane, and they also report anterior displacement of the pleura, but they report that it was very difficult to visualize the needle or track the needle. As you would imagine, the angle of insertion is quite steep, and therefore visualizing the needle in this approach can be quite challenging. They were also report that they were difficult to visualize the needle tip as it was advanced, particularly in the sagittal scan. So therefore, when you do a sagittal scan, you have poor visualization of the pleura, the anatomy, and the advancing needle. So as a result, I have abandoned the use of the sagittal approach, because there are alternative approaches that may allow you better visualization of not only the anatomy, but also the advancement of the needle. And this is where the transverse scan comes into play. As opposed to a linear transducer, we use a curved linear transducer, as you see in this cartoon. The transverse scan is performed as a sequence, because it's important to know the contiguous anatomy and to be consistent with what you are performing. As you will see here, the first window would be the level of the transverse process and the rib. The second window would be just below the rib at the tip of the transverse process. And finally, we locate the inferior articular process. Now, the inferior articular process for pain physicians are very simple terminologies. But for anesthesiologists like me, maybe it wasn't. So if you look at the inferior articular process, it articulates with the superior articular process to form the facet joints. The inferior articular process is very closely related to the intervertebral foramina. So therefore, when you perform a scan, you will see these three windows. On this one, you see the spinous process, transverse process, the rib. When you go below the rib, you see only the tip of the transverse process with the pleura. And if you just go below the transverse process, you see this hyperechogenic structure, which is the inferior articular process with the pleura and the ligament complex posteriorly. So this is essentially what you see at the level of the transverse process is the apical part of the paravertebral space. Actually, the true paravertebral space is in the dark side of the moon. However, if you go below the transverse process, you will see that at the level of the articular process, you can see, or you can imagine in your mind's eye, the entire paravertebral space, which is that wedge-shaped space. This has been correlated with computerized and magnetic resonance imaging, and we presented this at the last ASA in Boston. Then you can perform ultrasound-guided injection. This is at the level of the transverse process, which was first described by Dr. Shibata and their group, and the group from Pittsburgh have also described a similar technique, whereby you insert the needle from a lateral to medial direction. You insert the needle so that at the apex of the paravertebral space, as I alluded to before, you perform the injection, you will see anterior displacement of the pleura. While this is perfectly effective, we chose to perform the injection at the inferior articular process. And there are some reports in the literature on this by Dr. Lewitt and Dr. Gautier and the group. Today, we're proud to say we've performed more than 3,000 individual injections of these individual, either single or multi-level injections, and we've had no complication relating to this. So the ergonomics are like so. You can see the patient in the lateral position because we perform multi-level injection. We sedate them. We also give them some ketamine for analgesia. The needle is introduced from a lateral to medial, starting from T6, and we move up to T1, so that you don't forget which one you've injected. And you can see here the needle is introduced at quite a steep angle. And as you can see, the tip has now entered the paravertebral space. We always inject saline before the local anesthetic. This will confirm your needle is in the paravertebral space. If you see anterior displacement of the pleura, widening of the paravertebral space, and even increased echogenicity of the pleura because there is post-enhancement with the reduction in the acoustic impedance in the paravertebral space. So this is confirmed that your needle is in the correct position. We then inject the local anesthetic. I'm not proposing you should use echogenic needles, but our practice is that because the angle of insertion is quite steep in some of these individuals, especially in the upper parts, we tend to use echogenic needles. We've used this now extensively in many of our patients. It's become a standard of care in my unit, where we perform it multi-level with some modifications, and for that we have to stay tuned. And we use it with sedation, and we do major breast surgery in this, and this was also reported in the last ASA in Boston. So the point for you is that if you're performing ultrasound-guided paravertebral blocks, then you got to remember that although the inferior articular process, as I've shown you, is quite a favorable location, but because of its close proximity to the intervertebral foramina, we consider this a no-go zone. So we still place our needle in the lateral aspect of this triangle, like Dr. Shibata or the group from Pittsburgh, But now, because we can visualize this entire triangle, we believe you can get a better visualization with injecting. Inserting the needle close to this area throws the danger of intravascular injection, also injecting to dural sleeves. Fortunately, none of them have been reported so far. Also, you remember that visualizing the pleura in the upper parts can be quite challenging. So, as you see here, this is the articular process at the T1. The pleura is very, very poorly visualized. The anatomical reason as why this may be, because the pleura actually reflects away from the paravertebral area in the upper parts, in the dome of the lung. And therefore, in order to really visualize it, you have to tilt the probe slightly caudate. So, as I say, there's always a twist to something. So if you want to see the pleura accurately in the upper parts, you have to tilt the probe slightly caudate, i.e. direct the beam towards the pleura and you should be able to see it. So it becomes a transverse oblique view. The next few minutes I'm going to share with you some insights into neuraxial blocks, particularly ultrasound-guided real-time neuraxial blocks. Today with ultrasonography, you can very well perform transverse or a sagittal scan of the neuraxis. We have shown that you can get extremely exquisite images of the spine in both the transverse and the sagittal view. The sagittal oblique scan is the go-between to perform most of the interventions, because visualization of the neuraxis is extremely good. Through the interlamellar space, you can not only see the erector spinae muscle, but the ligament complex, the posterior complex here, which is the dura, the epidural space, the thecal sac, and the anterior complex. So when we use this, you can use ultrasound for neuraxial blocks as a pre-interventional scan or as a pre-procedural scan. This is most commonly used today. I don't need to allude as to what are the different applications for it in the interest of time, but I'll try and focus when the chips are down and you really need to do real-time interventions, what you have to do. Firstly, you have to do a paramedian sagittal scan because it provides the best visualization of the neuraxis. Also, when you do a paramedian sagittal scan, it's an oblique sagittal scan because you can imagine maximal amount of the energy is entering the neuraxial space, and you can see that the visualization of the neuraxis to the interlamellar spaces are extremely good. And when you do near real-time interventions, the needle is introduced paramedian, but because you're doing a neuraxial intervention, no ultrasound gel should be used. Because today there is some evidence that if you use ultrasound gel, you get inflammation within the neuraxis. This is an animal model study, and because there are no data in adults, so we still do not use any gel in these. We tend to use saline as the alternate coupling agent, and we reported this about 8-9 years ago, where we can use real-time ultrasound to do epidurals. So what you do is you do, this patient is in the lateral position, we perform a paramedian sagittal oblique scan, the needle is introduced from a caudocranial direction. From the non-dependent side, I like to introduce this time because this would be the non-dependent side and this would be the dependent side. Ergonomically, it's a lot easier to do it from the non-dependent side. There are proponents who do it in the sitting position, which is also perfectly all right. Then you insert the needle into the target interlamellar space that you either L3-4 or L4-5, and this can be easily identified using ultrasound. And once you insert the needle, you can track it through the in plane, and you can see it entering the interlamellar space and is now engaging the ligamentum flavum. What I'm going to show you after these slides, you really don't have to do it, because if you were to be able to guide the needle to this level, you should put the transducer down, use your loss of resistance, because the clarity of ultrasound is not good enough to tell you that the needle has now entered the epidural space. But during the time that we did this research, we used a spring-loaded automatic loss of resistance syringe. You can see the piston is retracted, and then when we insert the needle, you see that the saline would be ejected, and there is compression of the thecal sac and widening of the epidural space. These are morphological changes that occur within the neuraxis. Now you can imagine, ladies and gentlemen, as to why dry taps are not uncommon when you do a needle-through-needle CSC. Maybe the thecal sac is compressed in the area that you have done. This is for a discussion another day. Nevertheless, widening of the epidural space and compression of the thecal sac is a consistent finding we found in about 50% of our patients that we had studied during this time. Dr. Chin and the group have also described in plane the same paramedian approach for spinal injections. During this, you perform the injection, as we do, is your non-dependent side. Perform the local anesthetic injection. The needle is inserted in plane, and you can see it advance towards the interlamellar spaces. By the way, all images are not always like this. This is one of the best in my archives. So often you have patients of different age group and imaging is not as good. But nevertheless, if you can guide your needle to the interlamellar space, I think you've won the battle. And then you can advance it to the intrathecal space, which is just anterior to this. But one of the problems that is often or rarely reported, and it has not been reported, and we are in the process of reporting this, is dry taps are not uncommon when you do it from the dependent side. And it's easy to understand because the efflux of CSF is relatively slow, sometimes so much so that there's no CSF at all. Although the patient, you can see the needle in the thecal sac. We've injected local anesthetic, the perfect spinal anesthesia. So a dry tap may not always be a dry tap. So finally, in order to circumvent this, I'd like to share with you in the next minute or so a technique that we have developed, and we've gone through the pilot studies to show that it's possible, and a randomized study is now in progress, is to use a technique, an acronym with 4 letters, transverse in-plane dependent. So we're doing a transverse scan, but we're doing the needle insertion from the dependent side. I said, why not I add a couple of acronyms too? So what this technique involves is you insert the needle with a transverse interspinous view, with either the patient sitting or in the lateral position, and you can see here there's a series of images, a strict aseptic precaution with your transverse scan, local infiltration. The introducer needle is used as a guidance needle because the introducer needle is usually larger bore or larger diameter, and then through the introducer needle we introduce a 25 gauge spinal needle, and you can see the CSF here. What you see now in a video image is, if I can get it running. Okay, this is what you will see. You can see the needles introduced from the dependent side. We're aiming to go through the transverse space. And you can see the introducer needle being introduced here. And through the introducer needle, we introduce the spinal needle. And you can see this is the articular process over here. This is the dura. And at the moment of truth, you can see the dural puncture. And the CSF efflux is relatively quick. And therefore, we've had a very rare occasion of any problems with the CSF, and a randomized study now is ongoing, and we hope to report about that in the near future. So L5S1 is another anatomical fracture that I will talk more about in my talk on scoliosis. But ladies and gentlemen, you must bear in mind that the lumbosacral junction is an important route for neuraxial blocks when the chips are down and you have difficulty in neuraxial blocks. It is one of the largest interlamellar spaces. In fact, it is wider than the L3, L4, L5. And neuraxial blocks with these spaces have been described, but it's rarely used in the elective environment. There may be reasons for this, but again, we can't discuss in the interest of time. But once you perform it, it's quite easy to perform neuraxial block through this space, but again, be warned that dry taps are not uncommon. Although the patients may often report paresthesia, CSF efflux is relatively slow. Even sometimes when you aspirate the needles, you may not get any local anesthetic. And this is just to show you how the needle is inserted, and the lumbosacral junction, actually, the L5S1 is much more superficial than L3, L4, or L5 because of the posterior direction of the sacrum. So my concluding remarks is that I hope through this presentation I have presented to you, you will take home one anatomical fact that will help you to perform paravertebral and neuraxial blocks with success. If you do that, you've caught a real big fish, as I have done. Thank you for your attention.
Okay, so if I can invite the speakers to come up to the couch, and we're going to have